have diabetes, and more than 90% of them have type 2 diabetes. So this imbalance and incidence matches in all sectors, all scenarios. Before we go into, I think there is a separate lecture on this risk stratification, but we should first know that who are the diabetic patients who have highest risk, the very high risk for developing some sort of complications during any fast. So like evenly controlled type 1 diabetic patients where HbA1c is more than 9, severe hypoglycemia within 3 months, ketoacidosis within 3 months, hyperosmolar coma within 3 months, acute illness, advanced macrovascular complications, and pregnancy in diabetes treated with insulin. These categories should preferably avoid any kind of fasting. So these are called as very high risk of diabetic patients. That risk stratification is very essential once we decide to treat them. The other categories, like there is high risk, we have seen very high risk, then there is high risk, so they should they should also avoid fasting. It means there is diabetic patient with sustained poor glycemic control, weight control diabetes on mixed insulin or multiple doses of insulin, pregnant diabetic patients, CKD stage 3, performing intense physical labor, and well-controlled type 1 diabetic patients. Remember that for type 1 diabetic patients, even if they are well-controlled, they come in the category of high risk as far as fast is concerned. And there is moderate risk or lower risk who are well-controlled diabetics. Obviously, we know that nationally or internationally, the percentage of diabetic patients who have good control is less than 50%. So the category would have very less people treated with lifestyle alone or very borderline diabetic patients who are well controlled. Those patients will come in a very lower risk of diabetes. Okay. Now we will go one by one. We will first see how to control. We are specifically focusing on use of insulin during this fasting period for type 1 diabetic patients and type 2 diabetic patients. And what would be some practical guidelines? Like for type 1 diabetic patients, so initially there would be some scientific evidences, clinical trials that we will go through. Then we will go through the guidelines, and finally we will directly jump to what will be the practical recommendations, how to actually manage the use of insulin during Ramadan period for the diabetic patients. For type 1 diabetic patients, no great trials are available. The data that is available is very limited, and as we know, as you are aware, whether a patient is fasting or not, for all type 1 diabetic patients, we are not recommending pre-insulins anymore. So basal bolus insulin is the treatment of choice for type 1 diabetic patients. Once or twice daily injections of intermittent or long-acting insulin along with pre-meal rapid-acting insulin. So a combination of basal and bolus insulin is essential in type 1 diabetic patients to control their diabetes. Because this is considered to be safer, because you are dividing the dosage into multiple injections. So this is considered to be safer and with less risk of hypoglycemia. These are the clinical trials. I have compiled all the clinical trials which have been done in type 1 diabetic patients during Ramadan. How insulin is to be targeted. The number is not red. You can see in this chart. 9 is the number of patients, and the second third is the duration of fasting. So the first trial was for a duration of 9 patients who fasted for 30 days. And what was the recommendation? What was the author's conclusion? 70% of the pre-Ramadan dose should be used. So that was a very important recommendation from this clinical trial. So whatever dose previously the patient was using pre-Ramadan, then 70% of that should be used to avoid hypoglycemia or to have adequate control. In the second trial, the trial insulin dosage may be reduced to 85% of the pre-Ramadan dose, then 75%. So simply the sum of all these trials is you should reduce the dose of pre-Ramadan to the tune of around 70%. That's the crux of all these trials. Now we switch to our 70% of the total dose. Like suppose the patient was already receiving 40 units, for example. So 70% of that approximately 24 units divided over 24 hours. So this is another trial in which there was it was found that this is a very important concept actually, which I would like to highlight. We have been using human insulin. There is a restriction in using human insulin that it takes around 30 to 45 minutes because we are using it subcutaneously. So to action of human insulin to start, it requires 30 to 45 minutes. We know that even our regular patients do not follow this practice. So the advantage over human insulin is the analog insulins which are available, either low rapid or glyco insulins which are available, which can be taken immediately before food intake, or it can be taken immediately after food intake also. So that is an advantage of using a short-acting insulin, analogs. So in this study, postprandial glucose, it was compared between a regular insulin and analog insulin. Insulin Lispro was used. Lispro is an analog insulin, right? And the action starts practically immediately after giving the subcutaneous injection. So you can see very well that when Lispro was used, the postprandial glucose came down fast, but the risk of hypoglycemia was less because human insulin has got a protracted action. It works there for 4 to 6 hours, whereas this insulin Lispro or this analog, they work hardly for 3 to 4 hours. So the risk of postprandial hypoglycemia is also reduced when you are using analog instead of a human insulin. So this was a trial which compared, this is specifically, you look at this was specifically for those diabetic patients who perform fasting during Ramadan. This was the, you can see that before sunrise meal, after sunrise meal, and before sunrise meal. So that they had mentioned. So the conclusion was the insulin analog, short-acting insulin analogs were found to be efficacious as compared to regular insulin, regular human insulin. So what are the suggested strategies for management of patients with type 1 diabetic patients? We are focusing on use of insulin during Ramadan. And if the patient already has type 1 diabetes, what should be our strategy? Look at this. 3 meals per day, basal bonus regime, good control plasma glucose usually requires at least 3 injections per day. So if a patient is taking pre-Ramadan, 3 meals per day and 3 times insulin, and second case during Ramadan, this is the change. Pre-Ramadan and Ramadan, that is the change. So pre-Ramadan the patient was taking 3 meals. During Ramadan there are only 2 meals. So then what is happening? The first strategy is use only 70% of previous insulin dose and divide it into basal and prandial insulin in a ratio of 60-40. As we have seen in our clinical trials. Reduce the dose by up to 70%, divide it into 60 and 40, 60 basal and 40 prandial, and divide prandial again into 2 doses. And that way, so previous, there is an example. If the previous dose was 80 units, during fasting, 70% of 80, that is 56 units used to be used, 34 basal before sunset meal, 22 prandial divided equally between the pre-dawn and sunset meal. Clear? So this will avoid the risk of hypoglycemia. However, the diabetes control would not be disturbed. Second strategy could be omit the afternoon dose of insulin and invert the morning and evening dosage so that the morning dose is given in the evening and the 50% of the evening dose is given in the morning. This is another strategy which we can use and it has been also found successful. Suppose previous dose is 80 units and that is the premix morning 40, regular 10 units and premix evening 30 units. So this we practice many times. In the morning patient is taking 40 units premix, 10 units short acting during lunch and 30 units during dinner. So we skip the 10 units regular insulin. During fasting, we are supposed to take 55 units, 40 units before sunset meal and 15 units premix before pre-dawn. So if you take the 15 unit premix before pre-dawn meal, obviously the daytime hypoglycemia risk would be reduced. So that is how this strategy is also found to be successful. But there are no clinical guidelines. So I must tell that I searched across all books, references, journals. For type 1 diabetic patients, these are all suggestions. As far as guidelines are concerned, it is not mentioned anywhere. Now we come to the major chunk of diabetic patients, that's type 2 diabetic patients. So judicious use of intermediate or long-acting insulin preparations plus a short-acting administered before meal One injection of basal insulin may be adequate in some patients, but most patients will require rapid or short-acting insulin at meals along with basal insulin. Hypoglycemia tends to be less frequent as compared to type 1 diabetic patients, but it is absolutely, there is still a risk, so we should always keep it in mind that there is a risk of hypoglycemia. So these are the various clinical trials with various recommendations. I will not go into details of them. We'll just see few of the clinical trials and quickly come to the recommendations. So this was a comparison between insulin detimate and bias 70 in diabetic patients during Ramadan. So the trials are less, but whatever trials are available, I have tried to collect them. This was an open label trial in 245 patients, and in which insulin detimate and bias 70 was used, and in the control arm there was a standard insulin regime based on ADA recommendation. And look at the results. Dosing adjustment, daily DID stands for daily insulin dose. So the daily insulin dose during Ramadan was calculated at 60%. So in this trial, they have played even conservatively. So they have taken the 60% of the dose before Ramadan. Bias 70 was given before pre-sunset meal, and detimate was given early in the morning. Just to tell you that insulin detimate is one of the very good modern insulin analogs. Basal insulin analog, which is practically a peakless insulin with very less risk of hypoglycemia. So when these two arms were compared, look at the study endpoints and safety was compared, and it was found that this was the age and all the parameters. These are the mean 4-point SMPG values during the days 23 to 30, and added that is detimate and bias 70 was non-inferior to the control arm. So whatever regular insulin therapy was being used, instead of that, if the patient was shifted on bias 70 at the sunset meal and detimate at the early morning meal, then this was found to be bias. Bias is a combination of 30% of short-acting insulin aspart and 70% of proton-related aspart. Intermediate. So it's a bias. 30-70 combination. Just like a mixed chart, it's a bias. No mix. The trade name is no mix. So no mix was given at sunset meal, and detimate was given pre-morning meal. And this was the result. It was found that there was no significant difference. It was not non-inferior. And adverse events also, if you can see, there were lower adverse events with this combination compared to control. So on one hand, you could maintain the adequate control, but on the other hand, the safety was established. So there was less risk of hypoglycemia, and that comes physiologically because, as I mentioned, it is a very stable and there are less chances of, these are called peakless insulins, especially detimate. So there are less chances of causing hypoglycemia even during this. So treatment with detimate and bias 70 was non-inferior to the control group, treated according to ADA guidelines. And this had a better adverse effect profile as compared to control. So that was an advantage. Comparison of insulin lispro and human insulin in type 2 diabetic patients during Ramadan. So this was another trial in which again they have compared the insulin lispro, which is a short-acting insulin analog, modern insulin analog, which has got an advantage over the regular insulin. So insulin lispro and human insulin, they are compared in 70 patients. These were OPD patients. In 70 patients, insulin lispro and human insulin was given. All patients received LPH insulin, that is the intermittent acting insulin, twice daily before pre-dawn and pre-sunset phase. Let us see what was the result of this interesting trial. So it is very obvious that, just look at these graphs, postprandial glucose control when you are using insulin lispro, that is a newer insulin analog. Obviously, it was better. The peak in the postprandial glucose is less, and the risk of hypoglycemia, distribution of hypoglycemia, it was also less when you compare with human insulin. So this is for the obvious reasons, because whenever you do human insulin, just I told you, because the distribution pattern is unpredictable and it can last for up to 6 hours. So there can be protracted hypoglycemia. So this was the comparison between two. So there was a better PPG control with lower risk of hypoglycemia. This was again another trial in which lispro mix 50 with human insulin mix 30 in diabetic patients during Ramadan. So, like patients who were receiving the regular human insulin combination mixed at 30 were compared with insulin Lispro mix 50-50, right? So, what was there were two groups were made, that human insulin mix 30 was given, and group 2 only human insulin was given twice a day. And what was the result? Like group 1, group 2, and the p-value. Changing to insulin Lispro mix 50 during Ramadan resulted in improvement in glycemic control without increasing the incidence of hypoglycemia. So this actually applies to whether the patient is fasting or not. It applies to the same, because these are the advantages given by the insulin analogs. So just to tell you that in few of the countries they have stopped using even insulins. In UK they have switched entirely to analogs because of the limitations being there. We cannot do that because of the cost factor, obviously, and we need to continue, but we have to ensure that we give proper instruction to our patients when to inject, because that timing and this insulin techniques, where to inject, when to inject, how to inject, that is very important. If it is not followed properly, then the diabetes control won't be achieved and risk of hypoglycemia would prevail. So this was again a combination of insulin Lispro mix 25 and human insulin 30-70 during Ramadan. This was again an open label multicentric trial, and it was for 151 patients, and this was the result. You can see mean daily insulin doses were identical for both treatment arms. However, the control was better when you are switched to the analog insulin. So dose adjustment for a premix insulin during Ramadan, how you should adjust the dose. So once daily dosing. So if the patient is taking once a day dose, then you can continue taking the normal dose at iftar, but that should be 70%. That we already decided. It should be around 70%. Twice daily dosing, you should reduce the sahur dose by 20 to 50%. If the patient is taking 3 times daily dosing, you should carry out dose titration every 3 days. So there is a rule in insulin dose titration that, like for example, especially in the case of analogs, to achieve its full potential therapeutic benefit, you need to give it continuously for 3 to 5 days. So insulin dose adjustment and titration has to be done every 3rd or 5th day preferably. You should not be like every day it should not be changed, right? That is the concept which is very important to understand. This is again insulin experienced type 2 diabetic patients, BID. The study design of that, this is the latest trial, IDEC aspart. IDEC asp is insulin degludec and insulin aspart combination. It's again a modern combination which involves both the analogs, and in this particular trial, IDEC aspart with OADs, oral antidiabetic agents, were compared with bias 30 2 times with OADs. Bias 30 is again no mix, and that is Razodec, and it was compared and it was done for entire 32 weeks. And let's say all of these patients did perform the 30-day fasting, right? And this was the frequency and the details of the trial, and choice 1 changes, like we just go directly to the results of this trial. Yes, results. You can see that these two graphs are very clear that when you are using the regular, the Novomix insulin, and when you are using the analog insulin, that is the right, you can see that the diamond is IDEC as BIT, and the square is bias 30 BIT, and you can very well see that there is a reduction in HbA1c that is significant, and risk of hypoglycemia, regular hypoglycemia as well as nocturnal hypoglycemia is reduced when you are combining a modern insulin analog, that is either insulin aspart and degludec, insulin degludec. So the conclusion of this particular study was there was 62% lower rate of confirmed hypoglycemia, 74% lower rate of nocturnal hypoglycemia, and 35 to 50% dose reduction of 1 week. Look at this one important aspect is we are really worried about hypoglycemia even in our patients who are eating normally. And even during this fasting period, it is our nightmare that patient should not get hypoglycemia, right? But just to tell you that world over, literature tells us that the risk of hypoglycemia is more with oral antidiabetic agents, especially sulfonylurea, as compared to insulin. So if you judiciously use insulin, then probably you can negate the risk of hypoglycemia very efficiently. So just few guidelines about how to dose adjust, how to adjust the dose during the Ramadan period. And based on, depending on which type of insulin the patient is using, right? So if the patient is using either Degludec, Detimid, Glargine U100 or Glargine U300, these are obviously the preferred options, because all of these insulins, as I mentioned, they have a lot of flat action profile. These are peakless insulins. So there is a lesser risk of causing hypoglycemia when you are using either of these insulins. These are the preferred options. Consider reducing dose by 15 to 30%. So we have seen that our total dose has to be brought down to around 70%. But if we are talking about the basal insulin or analogs, it should be reduced by around 30%, right? And NPH is a very good insulin, but however, it is unpredictable. There is intra-patient, inter-patient, intra-day and inter-day variation whenever NPH is used. So we have to reduce dose by around 50% when the patient is using NPH. That is very important. Aspart or faster aspart, which is now available, and glulysin or Mispro, these are again preferred options, and dose reduction should be to the tune of 25 to 50%. And if human regular insulin should be switched, that is one very important recommendation. It should be switched preferably if it is unavoidable. Then these human insulin should be switched to analog insulin for obvious benefits of causing lower risk of hypoglycemia. Biphasic insulin aspart, consider switching to an alternate regime, but if you want to continue, then reduce to dose by 50%. Right? So that is a clear-cut guideline to be used. Now, for individuals managed on any insulin regime, less intensive glycemic targets during Ramadan, aiming for fasting and preprandial SMBGs of 5.5 to 7.5 are preferred. So this is during this period, our targets, even ADA tells us that now your target should be tailor-made. It should be according to the patient's susceptibility. If the patient is vulnerable, then your target should be liberal. You should accept, at least during that period, you should accept that even if the blood glucose is on the higher side, you should be able to accept that. Insulin dose adjustment to achieve these conservative targets should be individualized, taking into consideration insulin sensitivity and total daily dose of insulin. So there is a technique to calculate what is the insulin sensitivity. There is a technique to calculate TDD or DID, like total daily dose of insulin. That depends on your BMI, that depends on your so many factors. So it could be a totally separate lecture how to calculate the insulin sensitivity. But to put it simply, insulin sensitivity is how much reduction in plasma glucose is possible with 1 unit of additional insulin. That is insulin sensitivity. So normally, if the insulin sensitivity is good, then you achieve a level of around 40 to 50 mg/% of reduction. If insulin sensitivity is poor, you can achieve around 20 to 30% of reduction in plasma glucose. So you need to calculate insulin sensitivity, you need to calculate total insulin dose, and then accordingly finalize what would be the insulin regime that is suitable for diabetes. Individuals have a complex regime, especially those with an increased risk of hypoglycemia, should be evaluated by a diabetes management team. That is very important. Type 1 diabetes, we have already seen what are the recommendations. Insulin decay, this is very important, one of the important complications. If unfortunately a type 1 diabetic patient develops diabetic ketoacidosis, then people with type 2 diabetes should monitor blood ketones when SMPG readings are anywhere more than 14 millimoles, that is to screen for decay. Those with blood ketones more than 0.6 should break their fast, take a supplemental dose of rapid active insulin, and re-evaluate their ability to safely fast during the Ramadan in the future. This is very important because it could be life-threatening. And another important thing is dehydration, which would further add on to this decay problem. So these are the guidelines that we are supposed to follow. Another important thing is monitoring of glycemic control. Many patients just forget this. Actually, we need more intensive monitoring during this Ramadan fasting time. Self-monitoring, that is SMPG, does pricking the skin invalidate the fast? Religious authorities agree that glucose monitoring does not invalidate the fast. So you can very well recommend diabetic patients should continue to check their glucose level. Will frequent SMPG increase the chances to break the fast? No, they will actually reduce the frequency and severity of hypoglycemic episodes so that fasting can be performed safely. We want safety, right? We want safety of the patients. So what should be the SMPG frequency? How frequently a patient should monitor their glucose? At least 5 times per day for type 1 diabetic patients, 2 to 5 times per day for type 2 diabetic patients. Type 2 diabetic patients not requiring insulin, they can individualize the SMPG frequency. Additional testing for periods of symptomatic hypoglycemia or hyperglycemia, you can put it. More you check, better you do. You can also use that AGP monitor. No? That is, you put in the sensor and just try scanning the monitor, you can get the result. They are fairly reliable. We have been using it in so many patients. So you need not remember, you need not prick every time. You can just put in the sensor, it will work for 14 days. You can put another sensor that will work for 14 days, that will end your fast duration, right? So that would be very useful. So when to break the fast? So that is a big question that is often asked about. So counseling to break the fast, treat the problem appropriately and seek immediate medical attention if there is symptomatic or documented hypoglycemia. Less than 4. Less than 4, if you convert in milligram percent, is around 72. So internationally there is a dictum that is called as 4 is the floor. 4 is the floor. So you should never go, the glucose level or plasma glucose level of any patient should never go below 4 millivolts. 4 is the floor, that is the lower limit. So if it is documented less than 4, then you should take some action, immediately some action has to be taken. And symptomatic hyperglycemia above 16.7 millivolts per liter. Then also very high, above 300, 350, 400 sugar. If you notice, then you need to break the fast. You need to do something. You need to take action immediately. You can use, as I was mentioning, there is a flash glucose monitoring, AGP monitoring. It's called as ambulatory glucose profiling, which you can use during Ramadan. This real time may be considered for type 1 diabetic or type 2 diabetic patients also, especially those patients who are on complex insulin regimes. Now, I have collected the guidelines from all the leading international authorities and associations as far as insulin type 2 diabetic patients is concerned. What IDF tells us is patients should be advised to monitor their blood glucose levels regularly during fasting. They should also be encouraged to consume a balanced and healthy diet, and healthcare providers should work with their patients to develop an individual plan. So one plan does not fit all patients. You have to develop an individual plan. Even ADA is talking on the same terms. The guidelines of American Diabetes Association are also same. You can look at the EASD guideline. There is one guideline given by Muslim Council of Britain that also tells that patients should be advised to consult with their healthcare provider before starting Ramadan fasting, and healthcare providers should work with their patients to develop an individualized plan for adjusting insulin dosage during Ramadan fasting. Patients should be advised to consume a balanced and healthy diet and should be advised to break the fast if they experience symptoms of hypoglycemia or to consume a source of carbohydrate to raise their blood glucose level. This is given by many world leading organizations. For India, if we specifically ask, RSOTI guidelines, they also tell that patients should be advised to consult the same. Even API guidelines, it should be advised to continue their insulin therapy during Ramadan fasting. API guidelines, okay. They should also be encouraged to monitor their blood glucose levels frequently and adjust their insulin doses as needed. Patients should be advised to break their fast if they experience symptoms of hypoglycemia and to consume a source of carbohydrate to raise their blood glucose level. Patients should also be advised to consume a balanced and healthy diet, including variety of foods and adequate hydration. Each and this, and one important point I would like to tell you that whatever the patient, whatever amount of water they are drinking during night time, that will take care of the probability of dehydration the next day. So they should consume more water during the night time. That is one important take-home message that we need to take. So based on all these guidelines, I have prepared 2 mnemonics. How to remember? Because you can see that all guidelines tell us the same thing. So what? Remember fast and firm. There are just two mnemonics. Fast tells us follow up with the healthcare provider before starting Ramadan fasting. A stands for adjust insulin doses in consultation with healthcare provider. S, self-monitor blood glucose levels regularly. T, take action if experiencing symptoms of hypoglycemia. So remember fast and remember firm. Firm stands for follow healthcare providers' instructions for adjusting insulin doses. Because patients are not that much empowered that they can take their own decision. So this will actually increase our burden as doctors. But anyway, for the safety of the patients, we have to devote ourselves for that. So they should follow our advice, inject insulin at the same time each day and close to the usual meal time. That's R stands for record blood glucose levels and insulin doses regularly, and M stands for monitor for symptoms of hypoglycemia or hyperglycemia and break the fasting if necessary. So if we just remember these two mnemonics, this is a nutshell of all the national as well as international guidelines, fast and firm, right? These are the two things which I would, just to summarize my entire talk. Judicious use of basal and bolus insulins at mealtime is the preferred strategy. Dose adjustment of insulin may be necessary to avoid hypoglycemia without compromising glycemic control. Most of the strategies for insulin adjustments are suggested by authors based on few small studies, and it is essential that clear guidelines we are still awaiting. But as of now, this is what is prudence, what is available as of now, that we have discussed. So just a concluding remark. So today we are all talking about ChatGPT, that is a artificial intelligence machine. So I asked ChatGPT what would be the best strategy to manage insulin during Ramadan fasting. And I asked it to give me answer first in one sentence and then in one word. So let us see. In one sentence, effective management of insulin therapy during Ramadan fasting requires close collaboration with the healthcare provider, regular blood glucose monitoring, and appropriate dose adjustments. And then I asked it, give it in one word, answer was collaboration. So the answer to all insulin problems, all insulin dosage adjustment during this period is collaboration. Good collaboration with the patient and doctor would prevent so many complications. Thank you very much.
Thank you very much. Sir, any comments for the chairperson?
Actually, this is from a very general perspective. As an ophthalmologist, I'm talking, I see that the whole management insulin based is very complicated. And definitely the patient, how many percentage of patients they really follow all that and are able to go through the whole of Ramadan without any incidents?
Sir, it's a very good question you asked, sir. I would like to tell just three things about that. First thing is, what are our targets? Okay, so we do not want any complication during this period. So no hypoglycemia or no excessive hyperglycemia that may lead to immediate, any emergency situation. Okay, so in practical terms, many patients would prefer to go in for oral tablets. They would say that even like patients come to us like, sir, अभी हमारा फास्ट है तो आप इंसुलिन बंद कर दो और टैबलेट पे शिफ्ट कर दो. लेकिन it is very, that's again I would like to tell you that it's a very tricky situation that if you discontinue insulin, then you may lose the control which you have achieved for the last so many years. So it is not a practical strategy. We need to continue insulin. And again, some people think that it is just a reverse of their regular dose. Like 30 units in the morning, 20 units in the evening. They will just try to reverse it. It's not as that simple. So again, I will come to the point that it should be consultation and counseling with the patients. And I tell you, sir, if patients, we give time sufficiently and we counsel them, then definitely they follow it with. That's my personal experience. As you are an ophthalmologist, I would like to highlight one important thing. The difference between regular human insulin and insulin analog. Regular insulin, human insulin has got the potential to stimulate IGF-2, and this IGF-2 can increase the neovascularization in diabetic retinopathy patients. So that way also, in terms of preventing complications also, it is prudent to switch over to analog insulins. So that would be my advice.
Thank you, Rupesh sir, for the basic talk.
Sir, total insulin requirement 70% to reduce the dose, then you divide it into morning, afternoon, night. if a patient has underlying stroke or an underlying ischemic heart disease or an underlying connective tissue disorder or an underlying chronic kidney disease or rheumatoid arthritis. So in such patients, it has been documented in journals that keep sugar levels more above 180 to prevent ischemic heart disease, precipitation of IHD, precipitation of stroke. It is there given in the Japanese side. So for such patients, how would you suggest for this?
See, the targets, we'll segregate your question, so it's a good question. I would like to divide it in two parts. One is an acute care setting, like you mentioned about stroke or any acute emergency or MI. There are clear-cut guidelines that it is desirable that you maintain the plasma glucose level between 140 to 180. That is as far as ICU or critical patients are concerned. That is for acute care setting. In a chronic care setting, if these chronic diseases are comorbidities, then there are guidelines which tell us that even HbA1c up to 8 is acceptable, right? So that is already we have discussed. So it should be tailor-made. That will depend upon. So there are factors starting from A to F which you need to consider. A stands for age, and there could be comorbidities. There are so many other factors: risk of complications, risk of hypoglycemia. So based on that, we have to keep our targets liberal. Not only during this period, otherwise also in these kind of patients. Yes.
Sir, in case of patients with liver pathology,
Yes.
how to adjust the dose same 70%?
There is no, as such, there is no guideline, but theoretically speaking, if the liver parenchyma is damaged too much, so there is a cirrhosis kind of stage, right? Then there will be further risk of hypoglycemia which would remain uncorrected, because the glycogen store is also gone. So in these patients we can further reduce the percentage. Logically, it could be even less than that. It could be even less than. Just one more thing, in these patients, actually this insulin glucagon is now available. Injectable insulin glucagon is available. It is you need to just prepare it and you can just inject it. It is available very well. So in case of severe hypoglycemia, like in these patients who are having cirrhotic patients or your parenchymal disease, then you can instantly give that, and at least for time being there will be rise in the plasma glucose level. That would be loose. But as you have rightly pointed out, in the patients who are having liver parenchymal disease, the dose would be reduced even further. Yes.
Sir, last question.
Yes.
Sir, ketone, one to the slide mentioned ketone bodies if they are seen in urine, so break the fast.
It was in blood, sir. It was not in urine. Yeah. So we see, just to tell you that we do not rely on urine ketone as of now. We have got blood glucose meters, blood ketone meters, right? And the cutoff of blood ketone is 0.6 millimoles per liter. If it is less than 0.6, it is non-ketotic. If it is more than 0.6, there is definitely ketosis. So it is dependent on blood ketone.
So, but ketone levels are present in blood as well as urine for more days, despite patient being having good primary control.
Yeah, that happens with urine, because the three ketone bodies which are available, one will remain in the urine and it will come even in blood ketone. So blood ketone is the first to get corrected. So we monitor blood ketone itself. We have stopped monitoring urine ketone. Yeah. So blood ketone should be, yes.
You said something while talking on insulin injection, that if we take the patient away from injections, take off injections and start on medicine, the patient, we may lose the control on diabetes. What exactly does mean here?
Like if in the pre-Ramadan period, the patient was using insulin, that means the patient definitely has requirement of insulin. Otherwise, nobody would have started insulin. So, if a patient requires insulin for keeping their glucose levels at normal level or at least acceptable level, and suddenly we discontinue that, it cannot be replaced by any of the available medications. That is the reason. So, pre-Ramadan, if the glucose control was good with insulin, if the patient stops that and shifts to tablet, or if the patient says that I won't take anything during this period, he may lose the control, because any day, for the daytime there would be fast, but during the night time the patient would be eating definitely. And apart from that, there are other factors which will cause imbalance in the plasma glucose. So, and even after post Ramadan, suppose you restart the insulin, you may require some time before you achieve the same control, and that duration would be a permanent loss. That is the case. Yes.
One should not forget the term glucotoxicity.
Yes.
If you remember glucotoxicity, then you will do the justice to the glucotoxicity. So glucose less you get there, higher will you obtain there. So keep that thing in mind. Glucotoxicity. It can get it. Go ahead.
Yes.
Sir, patient is taking insulin with OHs before Ramzan. During Ramzan, stop OHs.
See, it has to be case by case. Like depends on how was the HbA1c level. Suppose if the HbA1c level say it was less than 7, then maybe you can stop OH and continue only insulin. But if the HbA1c was more than that, then you need to continue OHA as well as insulin both in a reduced
70%.
70.
It's all tailor-made.
It's a tailor-made, it has to be tailor-made. There cannot be a standardized formula. Thank you very much.
Thank you, sir, for the beautiful discussion. I request the chairperson to kindly felicitate Dr. Rajan. I request Dr. Shafi sir to kindly felicitate the chairperson. Our next speaker is an intensivist consultant diabetologist at Icon Hospital, associate professor in emergency medicine department at NJ Medical College, Dr. Umar Khan, sir. He will speak on pre-Ramadan medical assessment and risk stratification with new risk score. I request Dr. Badar Zainul, sir, Professor and Head Physiology Department IAMS, and Dr. Salih Sheikh, sir, Pediatrician at RF Hospital, to kindly chair the session.
My topic is already covered by the former speaker. I am very blessed to go. So my topic was pre-Ramadan assessment and risk identification, new risk score from International Diabetes Association. As Ramadan is a pious month where the Quran was revealed, so we'll start with Quran ayah. या अय्युहल्लज़ीना आमनू कुतिबा अलैकुमुस्सियाम, ऐ लोगों जो ईमान लाए हो, लिख दी गई है या फर्ज कर दी है तुम पर सियाम है रोजे, कमा कुतिबा अलल लज़ीना मिन क़ब्लिकुम लअल्लकुम तत्तक़ून, जिस तरह से लिख दी गई थी या फर्ज कर दी गई थी उन लोगों पे जो तुमसे पहले लाइक ज्यूज एंड क्रिश्चियंस, लअल्लकुम तत्तक़ून, या ताकि तुम तक़वा कर सको या परहेज़गारी कर सको। अय्यामन मादूदात, दिन है ये काउंटेड, गिने हुए। फमन कान मिनकुम मरीज़ा औ अला सफरिन फइद्दतुम मिन अय्यामिन उखरा, फिर जो कोई तुम में से मरीज है या सफर पर है उनके लिए ये रिपीट होंगे, अय्याम रिपीट किए जाएंगे बाद में, बिकॉज दे हैव टू फास्ट आफ्टरवर्ड्स। सो फॉर दोज पेशेंट्स हु आर एक्यूटली इल, दे नीड टू repeat the fast, repeat the days afterwards. वलल्लज़ीना वलल्लज़ीना युतीक़ूनहु फ़िद्यतुन तआमु मिस्कीन, और उन लोगों में से जो ताकत रखते हैं फिदिया देने की, वो खिलाएं एक मिस्कीन को. So for those patients who are chronically ill, who are aged patients, who cannot do repeat fast, so they can feed a poor person. فَمَنْ تَطَوَّعَ خَيْرًا فَهُوَ خَيْرٌ لَهُ, फिर जो खुशी से बेहतर करे उसके लिए खैर है. وَأَنْ تَصُومُوا خَيْرٌ لَكُمْ إِنْ كُنْتُمْ تَعْلَمُونَ, और अगर वो रोज़ा रखे तो बेहतर है उसके लिए अगर वो जानते हो. This is the next ayah. युरिदुल्लाहु बिकुमुल युस्रा, अल्लाह ताला इरादा रखते हैं तुम्हारे लिए आसानी का. वला युरीदु बिकुमुल उसरा, और नहीं वो इरादा रखते तुम्हारे लिए परेशानी का. So the fast means to ease yourself, to detoxify your body and not to make you difficulty or pain. So the holy month of Ramadan falls on the 9th month of the lunar calendar. It is one of the 5 pillars of Islam. It involves fasting every day for 1 month from dawn to dusk. Fasting is not recommended for everyone. As already discussed, it has been exempted to fast for the patients who are acutely ill or chronically ill. However, majority of people living with diabetes choose to fast and sometimes choose to do in contrary with the medical advice. Because everybody is ready to go to Jannah and the rate is 1 to 70. आप रोज़ों में 50% की सेल करते तो लोग पूरे गुरु से दौड़ चढ़ाते हैं. 50% की सेल नहीं, it is 70 times. So we need to see that. So according to latest estimates from the International Diabetes Guidelines, then the figure includes 171 million patients for diabetes. We expect it to rise to 366 million. But by 2023, not by 2030, we are 463 million diabetic patients. And by 2045, it will be 700 million. So initially, 50 years ago, 40 years ago, it was malnutrition or malnutrition. Now it is malnutrition. We have shifted our favorite foods to pizzas, burgers. It is the effect of that. So Ramadan is widely observed across the world. A recent survey in 39 countries involving 380,000 Muslim population, median of 93% fasted during Ramadan. See, 93% fasted during Ramadan. So Ramadan is not just an obligation. It has got a social, psychological impact on the body and the mind of a person. He is so much devoted. नहीं है रोज़े तो रखने हैं, रोज़े तो नहीं छोड़ सकते. डॉक्टर साहब कुछ भी करो, रोज़े नहीं छोड़ने. So the epidemiology of diabetes and Ramadan, EPDS study, it is older study in which 42% of type 1 diabetes mellitus patients do fast and they have sustained the fast. And whereas 78.7% of type 2 diabetes fasted for at least 15 days during Ramadan. आप कुछ भी बोलो, रोग नहीं छोड़ते. So more recently, the Darmena study, that is the Middle East and North Africa study, type 2 diabetes patients study revealed that 86% of the participants fasted for at least 15 days. It is clear that fasting in Ramadan is very important practice and has a major impact on the management of diabetes in Muslim population. In addition, meals eaten during Ramadan are often large and contain fried and sugary food, which can have an impact on blood glucose control. So, अगर इफ्तार में फालूदा नहीं है तो ज़ुबैर का विश्वास नहीं करते. फिर कबाब नहीं है, समोसे नहीं है, तब करके समोसे नहीं मिले तो खाना नहीं खाते. So we do eat. People tend to focus on the 12-hour fast, but they remember or they forget the next 12 hours feasting. Fluctuations in blood glucose levels, particularly postprandial hyperglycemia, have been linked with oxidative stress, platelet activation, as well as development of cardiovascular disease in people with diabetes. So you get more of strokes, ILDs, because of this hyperglycemia cascade. You are more prone to eat more in the post-iftar period. So coming to my topic, pre-Ramadan risk stratification. Risk stratification is an important aspect of all diabetes and Ramadan recommendation. The scoring system was designed according to various guidelines. let's see the scoring system. If you could recommend this scoring system to everybody, and every one of you can take a picture of it, so that it can be utilized in day-to-day practice. So diabetes type and duration. Type 1 diabetes, the risk score is 1. Type 2 risk score is 0. Duration of diabetes, if it is more than 10 years, the risk score is 1. Because after 10 years, you tend to develop microvascular and macrovascular complications. If the duration is less than 10 years, the risk score is 0. Presence of hypoglycemia. Hypoglycemia unawareness, the risk score is 5. Recurrent or severe hypoglycemia, the score is 4. Daily mild hypoglycemia, the risk score is 3. Hyperglycemia 1 to 6 times per week is 2. Hypoglycemia less than 1 per week is 1. Whereas no hypoglycemia, the risk score is 0. Now, third part is characteristics of glycemic control. If the HbA1c levels are more than 9, the score is 2. If it is 7.5 to 9, the score is 1. And if it is less than 7.5, which is hard to get, it's 0. SMBG. So, in self-monitoring of blood glucose, as it is already been told many a times, that doing blood glucose levels by glucometer will not break your fast. You can do it routinely in the afternoon period when you feel dizzy or when you have perspiration. Where it is indicated but not conducted, the score is 2. Where it is indicated but conducted, suboptimally the score is 1. Whereas it is indicated and conducted, which is very rare to found, the score is 0. Acute complications, DKA and hyperosmolar coma. In last 3 months, the score is 3. DKA and hyperosmolar coma in last 6 months, the score is 2. DKA and hyperosmolar coma in last 12 months, the score is 1. Whereas no DKA or no hyperosmolar coma, the score is 0. Chronic complications of comorbidity, unstable angina, heart failure, GFR less than 30 per minute, ml/minute, the score is 6. So it is high risk. eGFR less than 30 to 45, the score is 4. Stable cardiovascular disease or eGFR 45 to 60 ml/minute, the score is 2. Normal cardiovascular or no cardiovascular disease or normal eGFR, the score is 0.
Score rate.
Yeah.
Are they consistent scores? That is, if you say the score is 3 last 3 months, that means each month is it 3 or is it an average of?
Average.
Average of.
Average. Pregnancy. Pregnancy BSL not within target, the score is 4. Pregnant BSL within target, the score is 2. Not pregnant, the score is 0. And it is preferably, Allah Ta'ala has told, it's preferable for nursing or lactating females or pregnant females. They can avoid fast. They can give fidya and they can complete their class later. Frailty and cognitive function. Impaired cognitive function, the score is 4. Frail 3. More than 70 years old, no home support, the score is 1. No frailty or loss in cognitive function, the score is 0. Physical labor, intense physical labor, the score is 1. The physical labor like Dr. Sohail does is 1. No physical labor like Dr. Umar, the score is 0. Previous Ramadan experience, overall negative experience, score is 1. No negative or positive experience, the score is 0. Fasting hours, like in US, Canada, Greenland, if the fast is more than 16 hours, the score is 1. Because if it is more than 16 to 18 hours, the fuel of body shifts from...
Universal score for
Yeah.
everyone.
Yeah. Because if the fasting hours are increased, as in US or Canada where the fasting is more than 20 hours, in Greenland is for 22 hours, the body fuel which is glycogen initially is shifted to ketones. So that you have a high possibility of landing in ketosis. If the fasting hours is less than 16 hours, as in India, the score is 0. Diabetes treatment, multiple daily insulin injection, the score is 3. Basal bolus insulin pump, the score is 2.5. Once daily mixed insulin, the score is 2. Basal insulin, the score is 1.5. Glibenclamide, which is not used nowadays, the score is 1. Gliclazide MR or glimepiride, the score is 0.5. Other therapy not using sulfonylurea or insulin, the score is 0. In the previous lecture, doctors have taught us about that analogs, but I want to share one point. All the type 1 diabetes patients are poor patients. They cannot afford analogs. And the cadre which we are serving, and the people which we are seeing, they are all poor patients. Type 1 diabetes are poor. They cannot afford analogs. So it is better if they can, then we should omit the morning NPH dose or reduce the NPH dose by 50%. So finally, if the score is 0 to 3, the score you come in the low risk category, means you can fast easily. If the score is 3.5 to 6, it's a moderate risk. If the score is more than 6, you are high risk to keep the fast. And in a nutshell, I want to tell you, if the patient is having unstable angina, chronic kidney disease stage 5, then he should not fast. Type 1, if you have better sugar control, if you have good hypoglycemic awareness, then you can fast with proper guidelines and proper insulin adjustments. But as I have told earlier, everybody wants to fast because everyone has to go to Jannah. Next slide. So as Udu Sahasram has told, the month of Rajab is month of planting the seed. Month of Shaban is to irrigate the crop, and month of Ramadan is to harvest the crop. So sir, the month of Rajab and Shaban are our months. These are the months of the doctors. They need to do hard work on the patients so that they follow regular advice, they follow regular medications, they control their blood sugar levels, they do walk more, so they can become lean and thin and fit for Ramzan. So we need to make them fit for Ramzan before posting them for Ramzan. So the strategies to ensure the safety of individuals that are fasting in all these categories include Ramadan focused medical education, which is lacking. A pre-Ramadan medical assessment including a robust assessment of hypoglycemic awareness. इतने टेस्ट करने पड़ेंगे क्या? ये क्रिएटिन 2 महीने पहले सोहेल सर कैंप में कराए थे, अब वो चलेगा नहीं क्या? So, following a healthy and diet and physically active lifestyle, frequent self-monitoring of blood glucose or CGMS. I preferably advise that we should ask every diabetic patient who is on insulin to buy a glucometer and to have daily checking. Rotation told like 5 times a day, it is not practically possible. So at least 2 times a day in the afternoon period where we have higher risk of hypoglycemia. Modification to treat diagnose, stop sulfonylureas, shift over to DP4, metformin. The initial risk assessment can change. For example, if the risk is modifiable fibers such as glycemic control, frequency of SMG, or with the development of a knee complication, in these circumstances, the risk level will need to be adjusted accordingly. High risk individuals should not fast. Moderate risk individuals are advised not to fast, but they do tend to fast. But we need to modify them. We need to modify their medicines. We need to modify their diet. They also need to be aware of the techniques and strategies to decrease the risk. If individuals choose to fast, then they will need to be cautious and discontinue fasting. If any problem arises, we should tell them the signs and symptoms of hypoglycemia. If they feel dizzy, if there is perspiration, right? And they should have glucometer in hand. So if any time the blood glucose goes below 70, then we can break the fast and decrease the dose of next sahar. Low risk individuals should be able to fast. These individuals are at lower risk in terms of complications arising when fasting during Ramadan. However, as mentioned, circumstances can change, leading to a change in the risk scoring. Therefore, risk stratification should be conducted annually to review the level of risk in advance of Ramadan. Special populations. So this ayat was the last slides. Yuridullahu bikumul yusra. Allah Ta'ala चाहते हैं आपके लिए आसानी. वला और नहीं युरीदु बिकुमुल उसरा, और नहीं वो चाहते आपके लिए परेशानी. So for all those special populations, type 1 diabetes सब लोग रोजा रख रहे हैं, मैं नहीं कर सकता. वो तो डायबिटीज हो तो गोली खा के रखते हैं, मेरे को दे दो ना गोली कोई. But there is no गोली for type 1. He was only one for insulin. So recent studies involving young adults suggest that, and as I have already told, Ramzan is not just fasting. It has got psychosocial impact. सब लोग रह रहे हैं, मैं तो रह सकता हूँ. So, recent studies suggest young and adults suggest you that patient is stable, otherwise healthy, has good hypoglycemic awareness. That is more important. That he should know कि ये मैं hypo में जा रहा हूँ. If he has good hypoglycemic awareness and complies with the individualized management plan under medical supervision, then many of these patients can fast safely with reduction in the morning NPH dose. And one thing, regular insulin should be taken half an hour before sahur. So ask them to wake up for tahajjud, pray tahajjud, take regular insulin, and then sahur. नहीं खाता सर, खाता हूँ उसके बाद तरावी पढ़ने में गुड़ीगन के कबाब खा लेता सर. The elderly, many of the patients have enjoyed fasting during Ramadan for many years. They have been doing it for the lifetime. And now you cannot tell them कि आप रोजा नहीं रख सकते. And they should not be categorized as high risk based on a specific age, but rather they should be categorized as high risk if they have certain comorbid conditions. Unless if they have any comorbidity, unless they have any serious medical disease, they can have fast. Pregnant population. During pregnancy, the vast majority of women with type 2 diabetes would be treated with insulin, metformin, and glibenclamide. Insulin and glibenclamide carry a higher risk of hypoglycemia if they are fasting. So all those pregnant females, all those who are GDM, who are managed on metformin, can only fast. If you are on insulin or if you are sulfuric, then it is better that you should avoid fast. Many are concerned about hypoglycemia in Ramzan, but in pregnancy you are more concerned about postprandial or maternal hyperglycemia, which has a higher risk of neonatal hypoglycemia. So, hyperglycemia is a risk in maternity. So, which has got both risk for mother and baby. For a kind of better, she knows better. For this reason, pregnant women with pre-existing diabetes or GDM are advised not to fast, and they can give fidya and they can resume their fast after their pregnancy. Next slide. This is my last slide. So Ramzan is a month of fasting, not feasting. There are many sunnat and many hadiths for this. A believer eats in one intestine. He is satisfied with little food as Aisha eats. And there is one riyad from Aisha radhiyallahu anha. The family of Prophet Muhammad doesn't eat 3 consecutive days full meal. So in the lifetime of Medina, for at least 10 years they were in Medina, for 3 consecutive days they didn't eat full diet. So we tell ourselves that we are Ashish Rasul, but are we following it? There is sunnah of Prophet that 1/3 of meal should be food, 1/3 of water, 1/3 of air. बट अपना तो ऐसा है कि खाली रोड है, समुद्री का हाईवे है, भागो दूसरा तरफ, फिर बाद में रमजान मिलते नहीं मिलते हैं, फिर हैदराबाद टेरिस मिलती नहीं. So we should think about it, because Ramadan is not just fasting of food, it is fasting of our morals, it is fasting of our character. So it's all over for me. Thank you.
Thank you, Umar sir, for that enlightening session. You made us aware of all the Quran, ayat, what are the guidelines of Islam on Ramzan. I would like to ask one question about how many of us as a physician spend time in Ramzan focused medical education, and how much time should we give to one patient?
We usually lack this. सर नॉर्मली टेस्ट में कि तुम बहुत फास्ट पेशेंट देखते हैं और टाइम नहीं देते हैं, तो ये कहीं ना कहीं छुपता है. So yes, we are lacking in this because we are so busy. Because he has been a player of test and one day we are a player of T20 or T10. खुदने में निकाला रहता तो उतना नहीं होता. That we are lacking.
What are the guidelines for healthy diet for diabetes?
We need to eat more more of complex carbohydrates, because complex carbohydrates take time to digest, so you cannot get early hypoglycemia or hyperglycemia. So complex carbohydrates in the body, and as Professor has told, more of fluid in post iftar period. आप इफ्तार के बाद जितना पानी पी सकें, so it can maintain your hydration. And complex carbohydrates will maintain your satiety and will not end up in hyperglycemia or hypoglycemia.
When you take insulin during iftar, you said half an hour before, slow is
After iftar. Thank you.
The other question from us.
I think the message is start working as a doctor from Rajat. Already done. So your duty starts from Rajat. So see that you are going to make aware all the community, all the people aware of the Ramzan and its related issues. It's my customary suggestions to all of us that we should start making the people aware 3 months prior to the Ramzan. Get them ready for the examination. The Allah's examination that you are going to have here in the month of Ramadan. So when we appear for the exams, we are ready with all these wonderful studies. So let us come out with this approach. So we have to prepare for that. That's one thing.
And something we done like you have a set of your patients, your own patients. You can ask them to come 1 month before Ramzan, a common platform for all the patients. You do not give much time to individual patients. But like do not focus medical education and healthy diet and Ramzan training session for your patients. Right? Something like would be better.
Inshallah, like Cinema Academy will take the initiative.
Much better.
Thank you, Dr. Umar Sam, for this lucid and simple talk from this side. Two new things which I felt in this CME. The one thing, being a pediatrician, we always listen about infectious diseases. And it's something new that we are listening about non-communicable diseases. We always listen about fever, and actually there is one CME is going on at Ajanta and etc. And it's on fever only. So it was something different. I was thinking of going back to listen to, but I liked this CME, that's why I stayed there. Secondly, it was also very nice to listen about the Ramzan and its complications, all that from Dr. Indurkar sir and Dr. Professor. It was just a nice experience. They were talking about what are the Islamic legislation and all that, about Ramzan and all that. So these two things very new for me. Thirdly, we should not forget about the purpose of the Ramzan. Ramzan is not the purpose. Keeping Roza is not the purpose of this thing. The purpose is that we should la'allakum tashkurun. This is the answer given in the Quran. So that we can thank Allah subhanahu wa ta'ala as He has revealed this Quran to us. He has given us this guidance. If He would have put us in the hell without giving a guidance, that would have been a zulm. So the main purpose of the Ramzan is that we la'allakum tashkurun. We should thank Him for He revealing the Quran to Prophet Muhammad sallallahu alaihi wasallam. But the real purpose will be achieved only when we try to understand the Quran, try to implement it in our life, try to spread the message of the Quran. That is the main purpose. The keeping Ramzan, keeping Roze is not the purpose. And the second and the most important purpose that is mentioned in the Quran is शायद कि तुम में तकवा पैदा हो जाए. लअल्लकुम तत्तकून. So second thing is we should understand the meaning of the word taqwa. Taqwa, I will be better to elaborate in Urdu language, Hindi Urdu. जैसा रोजे में हम चाहे तो अकेले में जाके पानी भी पी सकते हैं, है ना, खाना भी खा सकते हैं, किसको मालूम पड़ने वाला है मैंने रोजा रखा है अभी. लेकिन हम सिर्फ इसलिए नहीं करते वो चीज़ क्योंकि अल्लाह देख रहा है. तो ये 1 महीने की ट्रेनिंग है जिसके जरिए हम 11 महीने ऐसी बिताना चाहिए कि जिस चीज से अल्लाह ने रोका है उससे रुक जाए. दिस इज द मेन पर्पस ऑफ दिस रमजान. एंड अनलेस एंड until that purpose is achieved, it will be this keeping. This is अल्लाह ताला तुमसे भूखा प्यासा रखना नहीं चाहता है. वो चाहता है कि तुम्हें तकवा पैदा हो. We should not forget this. In this whole scenario, I think this is very important and we are missing that part. Thank you for giving me this privilege of being moderator of this session. Thank you.
Continuing with the same thread, I just want to share one thing that after Ramadan, inshallah, we are starting an Arabic grammar class for all doctors. So I thank MELLITUS Academy to giving me opportunity to share this message that inshallah after Ramadan, कि जैसे पढ़ना सब पढ़ लेते हैं, एवरीबडी इज रिसाइटर, बट हु अंडरस्टैंड्स? इफ यू रिमेंबर साथ ही साथ आपने बेटी बोले थे रब के माने क्या है इन पाकिस्तान फंक्शन हॉल. इट टेक मी डेज टू रीड दैट. सो हाफिज बन रहे हैं, सब पढ़ने वाले बन रहे हैं, बट समझ वाले कोई नहीं. सो एज डॉक्टर्स वी आर द क्रीम ऑफ सोसाइटी. It is expected from us and it will be asked to us in Akhirat, okay, what have you done for it? So inshallah after Ramadan, we will meet with everybody inshallah and hope everybody joins us inshallah. Jazakallah khair.
Thank you, sir. And while we were looking at you all so enthusiastically looking at the risk course, so Elite Academy, Dr. Shafi sir has decided that we will bring the scores and we will provide it on behalf of IIMSR and Elite Academy to all the practitioners so that it gets very easy for you to assess your patients. Thank you, sir. I request the chairpersons to kindly felicitate Dr. Omar. I request Shafi sir to kindly felicitate the chairperson. I call upon Dr. Tuba Fatima Madam, Professor and Head Pathology Department at IIMSR, for her topic on pathophysiology of diabetes mellitus. May I request Dr. Mohammed Sohail to chair the session and Dr. Farhad Iba Madam to kindly chair the session.
So with so many experts talking about diabetes mellitus, I'm going to just basically talk on going back to what is diabetes mellitus and etiopathogenesis. Alright, and we'll try to see which levels or at what points of etiopathogenesis of diabetes mellitus does intermittent fasting like Ramadan affect or influence. So let us see basis of diabetes mellitus. So everybody knows this is just a kind of revision. We'll go very quickly. I'll not take a lot of time. So it is a group of metabolic diseases causing hyperglycemia and affecting so many organs, but predominantly kidneys, eyes, nerves, and blood vessels. Okay, and we know what is the normal blood glucose levels, and to call it as diabetes mellitus, what should be RPS, what should be FBS, what should be blood glucose levels after 2 hours of, that is the standard dose of glucose. All this has been given by WHO in WHO classification of diabetes mellitus 2019 also, and in the HbA1c level. Of course, there should be signs and symptoms of diabetes mellitus like polyuria, polyemia, weight loss, etc. And we also know what is pre-diabetics, that is below the level of diabetics. So the fasting blood glucose levels more than 100 milligrams per deciliter but less than 126, and oral glucose tolerance test less than 200, more than 140. And we know that these pre-diabetics, about 1/4 of them in 5 years, they land up in type 2 diabetes mellitus. And they also have a high risk of development of cardiovascular disease. So diagnosing pre-diabetics is also a very important aspect nowadays. So this classification of diabetes was revised in 2019 by WHO, which has been accepted by all the international diabetic associations, and in which they have added some more types of diabetes. So we already know that type 1 diabetes, the first type of diabetes, which is less common as compared to type 2 diabetes. Type 1 diabetes mostly below 20 years of age, associated with mostly absolute insulin deficiency. Then the next is type 2 diabetes, which is the most common type of diabetes, and there is relative insulin deficiency in this because of beta cell dysfunction and insulin resistance, mostly associated with obesity, and it is an adult onset form. This is a new type of diabetes which has been introduced in the classification of diabetes mellitus, that is hybrid forms. The first one which is called as slowly evolving immune-mediated diabetes of adults. So this is a kind of diabetes which is part of metabolic syndrome, basically associated with single autoantibody generally. And the second is ketoacidosis-prone diabetes, type 2 diabetes mellitus. Then the fourth type of diabetes are other types, specific types of diabetes mellitus, which prone to hyperglycemia or altered function of beta cells, leading to decreased insulin secretion or insulin function. So there are a lot of different types of other types of diabetes mellitus, like those with genetic defects of beta cell development and function, those with genetic defects in insulin action, exocrine pancreatic defects, where the pancreas gets destroyed because of some disease, as a result of which even the beta cells of islet get destroyed, leading to decreased insulin production. Certain endocrinopathies, which basically produce hormones which are antagonists to insulin. Certain drugs which either directly go and destroy the beta cells of islets, or which interfere with insulin production or insulin action. Drugs and toxins, they were certain infections which can directly or indirectly cause destruction of beta cells of islets. Certain genetic syndromes which predispose increased risk of development of diabetes mellitus. Then one more category was introduced in this classification, that is unclassified diabetes mellitus. If it could not fit in any of the previous ones, then unclassified. But generally the initial phase of diagnosis of this diabetes mellitus should be given this particular category. Later on we can diagnose it gradually, what is the specific type. And the last, that is hyperglycemia, first detected during pregnancy. Now this actually now has been divided into two types, that is type 1 and type 2 diabetes diagnosed for the first time during pregnancy, and second is gestational diabetes mellitus, in which the hyperglycemia is below the diagnostic threshold for diabetes. So that was about the classification of diabetes mellitus. Let us move on to pathogenesis of different types of diabetes, predominantly type 1 and type 2 diabetes. So in type 1 diabetes, of course, what happens is there is this is normal, that is insulin is produced from beta cells and it causes glucose uptake in the peripheral tissues. But in type 1 diabetes, this insulin production is barred. The insulin production does not occur because of destruction of beta cells. And this destruction is influenced by a lot of genetic and environmental factors, but of course it is mediated by self-reactive T lymphocytes, which cause destruction of the beta cells. This leads to severe lack of insulin, and however, the destruction of beta cells takes a very long period of time, and the clinical features, they arise only after 70 to 80% of these beta cells are destroyed. So destruction starts many years before the disease becomes evident, and predominantly by self-reactive T lymphocytes. And what type of T lymphocytes? Some T helper 1 subsets of CD4 and CD8 plus T lymphocytes, which can directly destroy the beta cells. Also, autoantibodies have been diagnosed against various antigens in these particular individuals, which are also associated with the destruction of beta cells. This leads to necrosis and lymphocytic infiltration of the beta cells of Langerhans. And you can see this is what happens in the pancreas. You can see there is an area of destruction of the islets with infiltration of the lymphocytes. Of course, these particular individuals have a genetic susceptibility. As we can see, type 1 diabetes mellitus is more common with monozygotic twins associated with genes on HLA loci in chromosome 6 and generally associated with HLA DR3 and DR4 haplotypes. Also, some non-MHC genes are associated with the development of this diabetes. Of course, a lot of environmental factors have been implicated apart from genetic susceptibility, like a lot of viral infections have been implicated. These viruses they produce antigens which may mimic the antigens present on the beta cells, and hence molecular mimicry plays a role, leading to antibodies against the viral antigens destroying the beta cells also. Also, a lot of other factors like exposure to cow's milk in the early period of life to the babies, and lot of other factors have been implicated for development of type 1 diabetes mellitus in recent studies, like babies who are born with cesarean section are considered to be found to be at more risk of developing type 1 diabetes mellitus. Then the type of diet we give, cow's milk, introduction of various dietary products, and also decreased vitamin D intake has been associated with the development of diabetes mellitus according to newer studies. And it has been said that not only direct destruction of beta cells is one of the causes, that means beta cells are not only being passively destroyed, but they also play a role in the production of causing their own destruction. Like all the factors surrounding it generally lead to dysfunction of the beta cells, losing their identity, and ultimately these beta cells they die. So even the beta cells are playing an important role in production of type 1 diabetes mellitus. Moving on to type 2 diabetes mellitus, everybody knows it is the commonest type of diabetes mellitus, and what basically happens is, this is healthy, but what basically happens is there is insulin resistance, which is the most important mechanism in type 2 diabetes mellitus. So many factors, basically sedentary lifestyle, which is a very common trend now, sedentary lifestyle, various dietary habits leading to obesity, and of course all these particular factors are also show a genetic predisposition. So type 2 diabetes mellitus basically is a type of diabetes which may be influenced by intermittent fastings like Ramazan, basically, because we have seen in so many presentations, especially Suvenza's presentation, that intermittent fasting is generally associated with reduction to some extent of the body weight mass index, and may improve patients with obesity. Also there are lifestyle changes during Ramzan, basically. It's a kind of intermittent fasting when there are lifestyle changes with increased physical activity. So type 2 diabetes mellitus is the most important diabetes mellitus which may be influenced by intermittent fastings. Of course, genetic factors play a role in type 2 diabetes mellitus, and however, there is no evidence of autoimmunity in the development of this type of diabetes mellitus. But there are two important metabolic defects which are seen. So the first is insulin resistance, and second is beta cell dysfunction. So what basically happens? What is insulin resistance? We have seen that we have already seen, Sohail sir has already said that in intermittent fasting like Ramzan, the insulin resistance improves. That means insulin sensitivity improves, the insulin resistance decreases. So this is one of the very important facts regarding type 2 diabetes mellitus. So what is insulin resistance basically? Decreased ability of peripheral tissues who are influenced by insulin, like liver, smooth muscle, skeletal muscles and adipose tissue. So their response to insulin is decreased, and this can lead to many effects like high fasting blood glucose levels, high postprandial blood glucose levels, and increased amount of free fatty acids can also amplify or increase insulin resistance. This insulin resistance can be produced by a lot of genetic defects, okay, but these genetic defects, they play significantly less role other than the other effects like obesity. Obesity is one of the very important risk factor for development of type 2 diabetes mellitus, and fat excess, especially central obesity, plays a very important role. So why this central obesity? Because the central fat deposits, they are more lipolytic, okay, as a result of which they release a lot of free fatty acids in the blood, in the plasma. Now remember, the free fatty acids, level of free fatty acids is inversely proportional to insulin sensitivity. If the level of free fatty acids in the plasma is more, the insulin sensitivity decreases, insulin resistance increases, and vice versa. So because these central fat deposits are more lipolytic, they are prone to develop, produce more free fatty acids, leading to increased insulin resistance. So these free fatty acids have got a lot of effects like lipotoxic effects, and which ultimately lead to insulin resistance. At the same time, Sohail sir has already talked about leptin and adiponectin, which are basically hormones produced by the peripheral adipose tissue. And we know that leptin and adiponectin, generally they improve the insulin sensitivity. But in type 2 diabetes mellitus patients, what happens to these levels? They are lowered. The level of leptin and adiponectin is decreased, as a result of which the insulin resistance increases. As sir has already said that in intermittent fasting like Ramzan, even the levels of leptin and adiponectin, they improve, okay, as a result of which the insulin resistance decreases, sensitivity increases. So this also plays a very important role as far as the intermittent fasting is concerned. So coming to next, that is beta cell dysfunction. We have just seen insulin resistance, which is a very important aspect of type 2 diabetes mellitus. Coming to next, that is beta cell dysfunction. So insulin resistance is going to add hyperglycemia caused by that, is going to cause a lot of stimulation of beta cells, which will try to produce more and more insulin in order to take care of that hyperglycemia. But after some time they get exhausted, okay, as a result of which they fail. So that is what is called as beta cell dysfunction. And many of the times we find that there is also quantitative decrease in the beta cell mass, which are ultimately replaced by amyloid-like proteins. Okay, so this also may cause, may further impair the beta cell function. So you can see the beta cells have been replaced by homogeneous pink material, amyloid-like protein. So in type 2 diabetes mellitus, what basically happens is there is genetic predisposition definitely, then there are so many environmental factors we have talked of, and the patient suffers from insulin resistance. The central obesity leads to lipotoxic effect, glucotoxicity, and also incretin effect. This is an effect in which normally some of the hormones like GIP and GLP, they lead to insulin secretion by beta cells. But in this particular case, what happens? These particular hormones are altered. Their amount is reduced. Okay? So ultimately leading to type 2 diabetes mellitus. And of course, monogenic forms of diabetes. So that is about type 1 and type 2 diabetes. Okay? Now, monogenic forms of diabetes, we will not go in detail. And of course, what about pathogenesis of complications? Now we all know the pathogenesis of complications in diabetes mellitus are centralized around hyperglycemia. And very commonly in intermittent fasting, we find that this hyperglycemia is taken care of. Hence, there may be lesser chances of developing complications because of hyperglycemia, because of intermittent fasting. So, complications basically caused by persistent hyperglycemia or glucotoxicity. So these hyperglycemias lead to production of advanced glycation end products, and which may cause activation of various cells like macrophages, T lymphocytes, vascular smooth muscle cells, endothelial cells, which may produce a lot of cytokines. And these cytokines, they play a very important role in causing microvascular complications and also macrovascular complications. Also, there may be hyperglycemia intracellularly, which may cause activation of protein kinase C, and which may lead to a lot of other cytokines, which can cause neovascularization in diabetic retinopathy, vasoconstriction, increased deposition of extracellular matrix or basement membrane material, and vascular occlusion. Hyperglycemia may also cause increased glucose uptake in tissues like nerves, lenses, kidneys, blood vessels, which is insulin independent, and this can lead to increased oxidative stress in these particular tissues. So ultimately, what happens as complication of diabetes mellitus is there is macrovascular disease, which is basically accelerated atherosclerosis, which may lead to MI, stroke, lower extremity gangrene, or there may be microvascular disease like retinopathy, nephropathy, peripheral neuropathy. So I think here I finish off my presentation, and thank you very much for your patient hearing. Of course, intermittent fasting like Ramzan can help diabetes, but as all of the experts have said that it definitely needs medical supervision and intervention. Thank you so much.
I request the chairpersons to kindly share it.
Jazakallah khair, ma'am. I'm very fond of your presentation skills, and it's an academic piece to hear from. As you have rightly said, that pathophysiology of diabetes is very complicated. It takes at least 10 years to develop diabetes, because there are various stages, from a stage of insulin resistance, then hypoglycemia of prediabetes, then hyperglycemia. So in our clinical practice, we do see such stages. हमारे जो पेशेंट के चिल्ड्रंस हैं, बच्चे हैं, वो आते हैं and they are saying कि we are experiencing hypoglycemia, they are having symptoms of hypoglycemia. So actually ये जो crowd है pre-diabetes का, it is more than 170 million pre-diabetics, and diabetics are 77 million. There are 170 pre-diabetics in India. In world there are 320 pre-diabetics, 320 million pre-diabetics. तो ये बहुत बड़ा क्राउड है, इस पर मास लेवल पर अवेयरनेस की ज़रूरत है. और ये जो जितने भी यंगस्टर्स हैं, उनको अगर मैं दो बातें बोलना चाहूँ कि यू लूज वेट, डोंट अलाउ द फैट टू डिपॉजिट along your baseline, and second, be active, because we don't know what is coming towards us, and it is predicted that the prevalence may go as high as 30% in near future. Thank you.
Thanks a lot, ma'am, for the presentation. बेसिक्स काफ़ी और भी क्लियर हुए, नहीं ये चीज़ें पता चली, स्पेशली सब जो लोग फिजिशियंस हैं उनसे ज़्यादा हम लोगों को, मुझे बहुत बेसिक्स समझ में आए. When it comes to diabetes awareness, we as doctors, we know so many things, and we know that छोटी छोटी अपनी रोज़मर्रा की लाइफ में हम चेंजेस करके काफ़ी डायबिटीज़ को कम कर सकते हैं, प्री डायबिटिक स्टेज पर भी रोक सकते हैं. But it's our responsibility to spread this awareness also. So I feel that we should do something constructive, literally constructive, to go into the masses, and so that everybody knows some basics of diabetes. Because in every family, like अभी जो prevalence आप बता रहे हैं, तो हर family में तो है ही है. छोटी छोटी चीज़ें करके चेंजेस लाकर कई बार कॉम्प्लिकेशंस में पेशेंट इसलिए जाते हैं उनको पता ही नहीं रहता, बहुत सारी बेसिक चीज़ें पता नहीं रहती. दैट टाइम वी समटाइम्स फील कि इट्स आवर मीन्स एक गिल्ट फील होता है कि नहीं इनको मतलब ये पता होता तो इतनी प्रॉब्लम में नहीं लैंड होते हम लोग. तो आई फील दैट समहाउ कुछ टॉक्स अरेंज करके या किसी तरह से हम क्या कर सकते हैं टू गो इनटू द मासेस.
The concept of intermittent fasting has just arrived now here, a decade ago. But Guru Saraswati has told this concept 1400 years ago. The best voluntary fast is to fast every alternate day. The next in his line is to fast every Monday or Thursday. And the next in line is to fast on 13th, 14th and 15th of every month. So as Madam already told in her lecture, okay, there is amylite deposition and insulin resistance. And Sohail has talked in his lecture about autophagy. So this autophagy concept comes first in the next first 12 hours of fasting. There is glycogen depletion, increasing growth hormone, and after 60 to 70 hours there is autophagy. So this autophagy will reduce advanced end glycation products. It will reduce the amyloid deposition in your pancreas. So per se, if you follow this, then there are less chances of developing insulin resistance and developing diabetes. Again, as someone was talking, I think Sohail was talking about demand and supply. If the substrate is more, if there is hyperinsulinemia, then you down regulate the receptors and you will get insulin resistance. If there is no insulin level, you should reduce your diet. If you reduce your diet as advised by Prophet ﷺ, if you decrease the diet, then you will decrease insulin and decrease resistance. You are eating more. That's the thing.
Yes, calorie restriction is becoming more and more important nowadays, and it should be followed because that has got so many important implications. So fasting is one way in which we can restrict the calories and we can even make it habitual for our kids. I think.
And it comes free of cost.
Sorry.
It comes free of cost.
Yes.
And again, what the timing of food. Even I used to eat at 11:30 p.m. Even I used to eat at 11:30 p.m. Tummy, which you are saying now, is due to that. I think we should not eat after 7 p.m. maybe after Maghrib, but that's it. Because after 11:30 you are going to sleep with no burning of calories. So it's all diet and lifestyle modification, which is coming free but we are not taking. Thank you.
Thank you everyone for healthy discussion. I would like to request the chairperson to kindly felicitate our speaker, Dr. Fatima. I request Dr. Ali to kindly felicitate our chairperson. Thank you everyone. You can please take your seat. Finally, we came to the concluding remarks of today's session. I would like to request Dr. Altaf Qureshi sir, Dr. Nusrat sir, Dr. Ashi sir to kindly take their chairs. I request Dr. Shafi sir to kindly join them. Now I hand over mic to Dr. Shafi sir for concluding remarks.
Before we start the evaluation commission, I request Dr. Jawad Hashmi to offer bouquet and shawl to Dr. Altaf Qureshi sir. Actually, we have cut down one presentation that was from my side. Epidemiology live. I don't want to bore you all. In the morning, we had 50 wickets, and slowly the wickets went down, and we can see only 15 to 20 people. Till I take the session, they may also fall down. That's why, in that fear, please, sir, that's it. I request Dr. Zubair to felicitate our RF Fabri sir. He is the medical director at Rural Hospital, JIS IMSR.
ये सब ऑनलाइन हो रहा है बोले मैं करता हूँ बोले शाम वो ऑटोमेटिकली अपना क्रेडिट होता है बोलते हो फिर उस पर रजिस्ट्रेशन पे जाके देखने लॉग इन करने का अपने आईडी जो रहते हैं
I request Dr. Mohammed Sohail, Dr. Mohammed Sohail to offer a booking chart to Yusuf Fabri sir. Thank you, Dr. Sohail. So now we have come to the conclusion of today's CME. The CME was planned almost within 1 month period of time, and today we saw that there was a very good response. Just 3-4 days before we had only 15 registrations, and yesterday we had 40 registrations, but Alhamdulillah today we had 65 registrations. So please clap for yourself that you have offered so much immense, huge response for CME, and inshallah in the future also we expect the same response from you. So to begin with, I request Dr. Altaf Rezi sir to speak few words more.
Thank you, sir, that you mentioned the last session because they were feeling bored. I think it's with the speeches of the guests and directly going to me, what should I say? See, I can only say one thing. As far as diabetes awareness is concerned, what various people have been saying is very relevant in our times. What Umar also said is very relevant. But the thing is, the attitude of the people involved, the patients I mean, खाते पीते घर का है इसलिए मोटा है अच्छा खासा है मेरी खाने का जवानी में खाने का खाना आपके खाने का खाना खलिया छोना खलिया कभी रात में 2 बजे खाना खाना तो खलिया खाऊंगा तो ये these things have to stop somewhere and this will only be over a long period of time. This will not be overnight and this will due to gradual what you would say education of the masses as they come on forming their years. Don't do this, don't do this, don't do this. They will do what they will do, but in the end, somewhere some effect will take place, and some change will come in the society. I think this is a very good start that you have done. And I think I expect such more CMEs on the same lines, educational lines to be done in the future. Sure, but bariatric surgery for that. See, the thing is, we are all lazy people at heart. Nobody wants to work. Why has bariatric surgery come into existence? Because people are lazy, not ready to do exercise, not ready to cut down on their food and everything. So, doctors, they just do nothing. Cut down on the stomach, cut the stomach. And see, it is also based on the principle of what Rasulullah said. Eat 1/3 so that they are reducing the size of the stomach that you can eat only that much. That's the principle behind it. Ghrelin, leptin, everything will go down. If you put the fundus. But there's a downside to bariatric surgery as well. Because in the long term, you see, people are regaining weight. They're tending to eat, they're regaining weight. And the results have yet to come in. All the double-blind trials and everything, they are yet to come in. Another 10 years down the line, maybe you won't be doing it.
Thank you, sir. Altaf sir ये बोलना चाहते वाले बात है हमारे फादरी सर, he is very known for speaking, so I request him to talk particularly on this CME.
मुझे बहुत खुशी होती है, खुशी भी है कि एलाइट CMA ग्रुप और JM की तरफ से आज यहाँ CMA रखी गई थी और डायबिटीज़ के बारे में अवेयरनेस अमंग द डॉक्टर्स पैदा करने की कोशिश की गई है। टॉपिक बहुत अच्छे हैं और मैं लोगों को हमारे पास जो है उनको जानता हूँ दे आर मास्टर ऑफ दैट सब्जेक्ट और उनका नॉलेज डेफिनेटली आपके बहुत काम आएगा। मेरा एक छोटा सा सजेशन है तमाम डायबिटीज को कि रमजान से पहले अभी 11 दिन है, आपके जितने भी पेशेंट हैं उनमें आप 2-3 सेशन लेकर अवेयरनेस रिगार्डिंग डाइटरी हैबिट के बारे में अगर करें, हो सके 10-15 का ग्रुप बुलाइए और बुलाकर उनको डाइटरी हैबिट के बारे में कीजिए। तो रोज़ा तो दिन तमाम रहते हैं सब, शाम में जो शुरू होता है समोसा कचौरी समोसे और शरबतें वगैरह ये वो, अब दिन तमाम तो रोजे से थे, रात में थोड़ा एक गिलास शरबत पी तो काम हुआ। इस हिसाब से जो चलता है उसके बारे में मालूमात दें तो बहुत फ़ायदे का रहेगा और फ़ायदे से उनको बहुत फ़ायदा होगा और उसकी वजह से बाकी के लोगों को फ़ायदा होगा। ये आप कोशिश कीजिए, मेरा सजेशन है। और जो आज CME हुई है 65 लोगों को अटेंडेंस के साथ जो CME हुई है ये काबिल मुबारकबाद है। मैं ऑर्गेनाइजर्स को मुबारकबाद देता हूँ और उसके साथ साथ ऐसी उम्मीद करता हूँ कि ऐसे सब्जेक्ट पर और आगे भी ऐसे CME का अरेंज किया जाए और उसका अवेयरनेस हो। अवेयरनेस होने के बाद उसका तो बहुत फ़ायदा नॉट ओनली डॉक्टर्स को, डॉक्टर्स के पेशेंट को भी उसका फ़ायदा होगा। इसकी मुझे बहुत तवक्को है। मैं अल्लाह से दुआ करूँ कि ऐसी CME को आगे भी ऑर्गेनाइज करने की तौफीक अता फरमाए, उसके साथ साथ उसको कामयाब भी करें। अल्लाह ने मुझे बुलाने के लिए और मुझे आमद देने के लिए मैं ऑर्गेनाइजर्स का शुक्रिया अदा करता हूँ। जज़ाकल्लाह।
बहुत शुक्रिया सर। सर हमें
It's not about the diabetes. It's not about the dietary habits. Basically, we miss the logical and rational approach towards life, especially in the community. Not only about the disease control, but other aspects of life also should be controlled. Once a person becomes rational, logical, and analytical, then only he can be useful to control the disease and its problems. It's not about only diet alone. You see other aspects of the human life, especially about the community. What you see actually is total picture approach towards study, towards lifestyle, towards रात को जागना, सुबह 10 बजे उठना, everything whatever you can say. And from Good Line to Cut Gate. Who do you think the hotels are full and full? Who is eating actually? When I go to my clinic, the road to clinic is totally blocked by the haphazard vehicle. It's not about the diet alone, it's about the lifestyle. And unless and until you follow the Quran and scientific approach toward the life, it's not possible.
Thank you, sir. Thank you. Now we'll start with the distribution of certificates. So I request the delegates to collect the certificates from our dignitaries. So we'll first start. I hand over the mic to Dr. Jawad. You can give the names and the release of the certificates.
Surena sir.
हाँ?
सैयद अमरुद्दीन मुजफ्फर अली, डॉक्टर मुजफ्फर अली, डॉक्टर खान सुलेमान, sir, please take a seat. I request Dr. Fadil sir to kindly distribute. Sabri Wajid Ali Khan. Dr. Farah Sheikh. Dr. Khan Faizul Rahman.
तो कॉलेज से उनका हुआ
Dr. P.S. Gowns.
अरे बहुत बुरा बोले यार
I request Dr. Nusrat Faruqi sir to kindly speak. Dr. Askari Muhammad Yasir. Dr. Zameen Ali Qasim. Dr. Khazi Asim Zafar. Thank you very much.
So now we have come to the end of today's CME, I can say, and Alhamdulillah that we have completed it successfully. Please check that you have given your registration number correctly, because we have to submit it to Maharashtra Medical Council and the 2 credit points will be credited to your registration number. So again, in the last, before we conclude, I request Khadir sir, please. Please felicitate our 2 pillars, Dr. Jawad Hashmi and Dr. Zubair Khazi, that they have taken a lot of efforts to organize this CME. So please offer a shawl and bouquet to them. अब आपकी मदद नहीं ना सर, काम हो गया ना काम शुरू हुआ सर, देवता में काम शुरू हुआ, the work has started. Khadir sir. These 2 people, they came to me like, sir, we will like to do something in Aurangabad. Then I got motivated and then we started that we will definitely do something. So that was the point where we decided that we will conduct this type of program in future. Dr. Zubair Khan. और इन दोनों के साथ मैं भी हूँ, तो मैं चाहूँगा कि मेरे
Anyone from your side want to give review about what were the flaws of CME or something we can do for improvement, so it's welcome.
Alhamdulillah, it was indeed a very good work. And young ones, you are doing very well. you are doing what we would never do. So you have started a very good thing. Keep it up. Let it
Certificate
go
दे रहे
on.
हैं अभी से?
Let it go on.
सर्टिफिकेट दे रहे हैं?
Let there be 100 flaws. That doesn't matter.
और दो देता
Starting
मैं।
a work is important.
वो उनका भी ज़ैनब मैम का भी और
Once
उनका
it's on the
भी।
way, flaws will go away. But you have to make a start. That's important. And it was indeed very wonderful. For the first time I feel very fresh in spite of being here since 10:30 a.m. It was indeed very good. And of course, for ophthalmologists, it's totally new. Thank you.
I again want to congratulate these youngsters. Starting has already been done. I will request to maintain the time, even increase. Don't stop over here. Don't to contain over this one. Try to increase it.
Thank you. I hand over mic to Dr. Shafi sir for vote of thanks.
गुलाब जामुन छोटे थे यार।
So I thank Allah subhanahu wa ta'ala that He has given the power and the will to organize this type of the CME. Then our college, our dean, our CEO, they have permitted us to come out of our institute and conduct such type of CMEs. So I'm very thankful to Dr. Azram Siddiqui sir and Dr. Ilyas sir for permitting us to conduct such type of CMEs. Then I especially thank Dr. Ehsan sir that who gave this idea of conducting such type of CME, and he has taken a lot of efforts to make this CME happen. Then all the speakers, particularly Dr. Indukar sir, Dr. Ajesh Rote sir, Dr. Mohammad Sohail, Dr. Duba Fatima, Dr. Umar sir, they also took a lot of efforts in a short period of time to present here topics. So I'm very thankful to all the speakers. Then I'm very thankful to all the delegates that you have taken efforts to spare Sunday time, leisure time to come and sit in this hall for a whole day. So I think you deserve the many congratulations for coming, and I'm very thankful to all of you. Then we are very thankful to Tausif Ahmed, the manager of this hotel, that he had offered us a very good place, and the food was also good. Except for that audio in the beginning, rest of the things, this location was really good, and I hope that all of you have enjoyed it. Then I thank our colleagues, Dr. Zubair, Dr. Fazi, then our students, Junaid, Aish. So all these people, even our residents, they came from our institute, they registered, they sat here for this program. So I thank all, and I hope that all of you will support us in the future. Lastly, I thank all our senior dignitaries that yesterday only we invited them that they have to come, and they came on time today, and they were present for our program. In spite that very few people remained in the last, but Musra sir, Adri sir, Altaf sir, they all have come. I am very thankful to you, and मैं उम्मीद करता हूँ कि आप तमाम लोगों की दुआएं हमारे साथ रहेंगी कि हम आगे चल के इस तरह के प्रोग्राम्स को ऑर्गेनाइज कर सकें। तो बहुत बहुत शुक्रिया आपका। जज़ाकल्लाह खैर।